Thank you, Eric, and thank you to the committee for the kind invitation. This talk is largely going to be evidence-free, so I thought I'd appeal to your, those are my disclosures, but I thought I'd appeal to your emotions. And some of you may recognize this chap. He's Robin Gibb, and the picture on the left shows him during his Saturday Night Fever days, and the picture on the right is him a few weeks before he died from metastatic colonic cancer. And this is what happens to the cancer patient. And the nutritional problems in the cancer patient go across the spectrum. So initially, you may get a biochemical problem, and then you get a functional problem, then you get loss in body mass, that's both lean body mass and fat mass, and finally, as Dr. Strasser so elegantly showed you, you get cachectic, and this is what Robin Gibb ended up with before he died. Now, while I leave you to read this definition of malnutrition, I'd just like to remind you that in the general patient, malnutrition can be both undernutrition and overnutrition. But in the cancer patient, it's largely related to undernutrition, and both of macronutrients and micronutrients, and this is combined with systemic inflammation, which can make the problem even worse. Now, there are several causes of undernutrition in the cancer patient. Some of them may have a depression in consciousness, they may have organic depression, they may be anorectic. The disease burden, especially in patients with pancreatic cancer, for instance, produces inflammation, and that can lead to further weight loss. Liver tumors and jaundice can lead to defects in the processing of nutrients and further nutritional deficiencies. The effects of treatment, that's iatrogenic problems, can also cause trouble. And then you have a poor diet. Patients nowadays are quite old, especially those coming with certain types of cancer. There is poverty, there's the alcohol abuse and drugs. Patients may have dysphagia, especially those with esophageal cancer, and those with bowel cancer may be obstructed and be vomiting. Finally, some patients may have pancreatic insufficiency, and even though the nutrient intake may be adequate, they don't digest the food properly, and so the absorption is reduced. Now, the problems with malnutrition were recognized as early as 1936 when Studley published his landmark paper. He looked at patients who were admitted with duodenal ulcer perforations. And he found that if the weight loss before the operation was less than 20%, the post-operative mortality was in the range of 3.5%. However, if patients lost more than 20% in body weight, the mortality was in the range of 30%. And 50 years later, this paper was published, and I'm afraid nothing much has changed. The prevalence of malnutrition in surgical patients is still high, and if patients are malnourished, there is a much higher complication rate and a much higher mortality rate than if they are well nourished. And I'm sure that if we repeated this study 30 years after this in the 21st century, we would find very similar results. Now, this is the key to nutritional intervention in the patient who is being starved or who is undernourished. And you see that if you have, in the green line, partial starvation, you take a long time to reduce your body weight and even longer to die. However, if there's complete starvation, as in hunger strikers, you take about 60 days to die from starvation. On the other hand, if a patient has starvation and inflammation, such as the critically ill patient or the post-operative patient with complications, you die in between 15 and 20 days of starvation. And so the key is the decision box where you've lost between 5 and 10% of body weight, and that's where the intervention needs to be introduced. If we wait for patients to lose 10 or 15 or 20% of body weight, we've probably missed the boat, and we're trying to lock the stable door after the horse has bolted. Now, Florian has given you a very elegant talk on both sarcopenia and cachexia, but I'd just like to remind you that the eventual result of loss in body weight is sarcopenia. And a lot of studies initially showed that sarcopenia was a main driver of complications. But the newer studies now suggest that it's mainly sarcopenic obesity that's a bigger problem than sarcopenia per se. And so patients who lose a greater proportion of muscle mass compared with fat mass are at greater risk. And this is an example of a sarcopenic patient. The CT scan on the top shows a normally nourished patient with the normal muscle area, whereas the CT scan below shows an appreciable loss in muscle area. Now, besides sarcopenia, myostatosis is attracting more and more attention. And this is a study that we recently published in patients with advanced inoperable pancreatic cancer. And we found that those who were myostatotic, as defined by muscle attenuation of less than 29 Hounsfield units on CT, those patients were more likely to have inflammation, they were less likely to tolerate chemotherapy, and they survived for a significantly shorter duration than patients who were not myostatotic. Now, cachexia is a complex syndrome, and it varies from a biochemical syndrome to a full-blown situation where the patient has lost both fat and muscle and is ready to die. And cachexia is associated with inflammation, there is insulin resistance, and there is increased muscle breakdown, muscle protein breakdown with decreased muscle protein synthesis. And I won't go into much more detail of this, but I'd just like to remind you that it's a combination of interactions between the host, the tumor, and the pro-inflammatory cytokines that are secreted by tumors, and the inflammation that the patient has that leads to the cachexia syndrome. Now, cachexia is present in almost all cancers, but the prevalence varies from cancer to cancer. So, for instance, in esophageal and pancreatic cancer, the prevalence of cachexia is greater than 80%, whereas in other cancers like breast cancer or favorable non-Hodgkin's lymphoma, the prevalence is in the range of 30%. And this is a combination of both reduced nutrient intake and inflammation that causes these changes. Now, what problems does undernutrition cause in the cancer patient? Well, they require more intensive treatment, they require a greater amount of high-dependency nursing, there is increased hospital stay, which leads to increased costs, and there is an increase in both morbidity and mortality, and patients may have a reduced quality of life, and they take longer after an operation to recover to where they were before the operation if they are undernourished than if they are well-nourished. Now, we know that malnutrition impairs outcome, but the main question we've got to ask today is, does nutritional support improve outcome? And if it does, how should we approach the problem? So what we've got to remember that nutritional support is only one small cog in the wheel of perioperative care. And it only works if the rest of our perioperative care pathways are good and give the patient optimum treatment. It will not compensate for inadequacies in other areas of care. So for instance, if I anastomose two ischemic bits of bowel together, no matter what nutritional support we give the patient, that anastomosis will leak and the patient is quite likely to die. We must remember that nutritional support interacts with other treatments. For example, drugs. We know that fluid overload can cause an ileus, and that can decrease nutritional intake. We know that to get the best treatment for our patients, we need to have integrated care pathways, such as the enhanced recovery after surgery pathway, which reduces perioperative inflammation, improves mobility, and gets the patient out of hospital quicker. And nutritional support must be delivered by a team that's well-trained. People shouldn't dabble in nutritional support because, again, you've got to look at oral nutrition, enteral nutrition, and parenteral nutrition. And if you don't get it right, nutritional support may cause patients harm. So what are the goals of nutritional therapy? Well, in the acute or short term, the most important thing is to recognize the risk of malnutrition, because if we don't recognize this risk, we will not intervene. And then we have to preserve function, we've got to minimize complications, avoid nutrient overload, and correct mineral, micronutrient, and electrolyte abnormalities. In the medium to long term, we've got to restore function back to the patient and improve quality of life. Now, we must screen our patients, and there are several screening tools that are available. You'll be familiar with the NRS 2002, and there are others in other countries, but a fairly simple tool is what we use in the UK, which is called the Malnutrition Universal Screening Tool. And it just looks at three areas. So the first is the BMI, the second is weight loss in the preceding 3 to 6 months, and finally the effect of the acute disease. And then you total these up, and if you get a score of 0, that patient's at low risk, and all you need to do is monitor that patient. A patient with a score of 1 is at medium risk and may need some sort of nutritional intervention in the form of oral SIP feeding. And finally, if the score is 2 or more, that patient is at high risk and needs support by a nutrition support team, and we need probably to feed these patients either enterally or parenterally to help improve the nutritional status and reduce complications. Now, the MUST may be a very simple tool, but the results are quite startling. So if you look at high-risk versus low-risk patients, you find there's a great increase in hospital length of stay in the high-risk patients, and in-hospital mortality, cumulative 6-month and cumulative 12-month mortality is significantly greater in the patients who are at high risk when compared with those who are at low risk. Now, despite this evidence, screening is not done as frequently as it should. And this is a German paper, a very pragmatic paper, which looks at real world. And you can see here that weight loss before admission was documented in only 64% of patients, or only 64% of patients were asked about weight loss. Body weight was measured in only 91% of patients, so we're still not achieving a 100% outcome over there. And most worryingly, about 4% of patients had absolutely no screening for nutritional status during the stay in hospital. So now coming to the next point is, once we've identified a patient who is malnourished or at risk of malnutrition, what should we do? Now, we need to give the patient both macronutrients and micronutrients, and the rule of thumb is that you give between 1 to 1.3 times the resting metabolic rate or the resting energy expenditure. And most patients need between 30 and 35 calories per kg per day, and usually half of this is given as fat and the other half as carbohydrate. However, this ratio can be modified according to patient needs. Protein requirements range from 1.2 to 1.5 grams per kg per day, but it's often quite difficult to achieve these requirements. And more recent studies have suggested that, especially in the early postoperative period and patients who've got a raging systemic inflammatory response syndrome, may benefit with permissive underfeeding, which amounts to about 20 calories per kg per day and up to 1 gram protein per kg per day. And this graph compares measured resting energy expenditure with predicted resting energy expenditure, and you can see that's a pretty good correlation. But the main point to note here is that there is no patient who has a resting energy expenditure greater than 2,000 calories per day. And so we don't need to overfeed these patients, and that was one of the problems we had with the Veterans Administration study, where patients were given 3,000 or even 4,000 calories per day, and they came to harm because of over-aggressive nutritional support. So we've got choices of routes, and I think the best route is the oral route, but this is not always feasible, especially in patients who've got dysphagia and those who've got a significant loss of appetite. And so the enteral route is the next best. This is usually tube feeding. It could be nasogastric or nasoenteric, or feeding jejunostomies could be used. And it is much more physiological, and it helps preserve gut function. However, there may be problems with access. Tubes tend to fall out. There may be aspiration, poor absorption, and a lot of patients who are tube-fed present with diarrhea and metabolic upsets. Parenteral nutrition is the method of choice or the route of choice in patients with intestinal failure, because there the gut cannot be used. And what it does, it guarantees delivery of the nutrients to the patient. However, again, there can be access-related complications. There can be line occlusion, misplacement, or displacement. Catheter sepsis is a major problem with parenteral nutrition. There can be metabolic complications, and it is more expensive than enteral nutrition. So the rule of thumb is that if the gut works, use it, but you've got to monitor the patient quite carefully. And if intakes are adequate or GI tolerance is not enough, you can supplement with parenteral nutrition. And what we have to remember is that enteral nutrition and parenteral nutrition are not competitive, but they are complementary. So the aims of perioperative management of any surgical patient, particularly surgical patients with cancer, are to improve function, improve survival and outcome, reduce complications, enhance the rate of recovery after surgery, reduce hospital stay and costs, and help the patient return to a normal life as soon as possible. So what is generally recommended? Again, the quality of the evidence is low, but the strength of the recommendations is high, mainly because this is common sense. You've got to assess patients about 2 to 3 weeks preoperatively and determine whether they have nutritional problems or not. And if they have nutritional problems, we need to support them with nutritional therapy for between 7 and 14 days preoperatively. Giving nutritional therapy for less than 5 days is probably of no use, and giving nutritional therapy for more than 14 days is of no added benefit. We need to avoid patients having prolonged periods of starvation preoperatively, and now most anesthetic societies recommend that patients can eat up to 6 hours before an operation and have clear fluids up to 2 hours before an operation. We probably don't need to support these patients nutritionally during an operation, but a lot of patients now, especially those undergoing colonic surgery, for instance, can drink on the day of the operation and can eat a reasonable amount of food on the first day after the operation. And post-discharge, especially patients where the intake is not adequate, we may have to give them supplements. And the best thing to give them at the moment is SIP feeds in the range of between 200 and 600 mils, which provide the same amount of calories per day in addition to what they're eating. So what should we give? We must give the macronutrients, the proteins, carbohydrate, and fat. Micronutrients, both the fat-soluble and water-soluble vitamins should be added. We should take particular care of the electrolytes and elements such as iron, zinc, copper, selenium, and magnesium. We must avoid overfeeding at all costs because that causes increased ventilatory demands. We can cause liver dysfunction and immunosuppression. And overfeeding with carbohydrate can lead to hyperglycemia and also the refeeding syndrome. So the refeeding syndrome is a potentially lethal condition that occurs when we feed patients indiscriminately without taking due care. And it's usually manifest with a precipitous fall in magnesium, phosphate, and potassium, mainly because the anabolic switch of feeding moves these elements into the cell. And so before we refeed these patients, we need to give them prophylactic thiamine. We need to check the potassium, phosphate, and magnesium and replace this if necessary before starting refeeding. Otherwise, we end up with the refeeding syndrome. And this is a chimeric sort of syndrome where the manifestations are across all organ systems and is very often not recognized. And unless you know about it, you won't recognize it and you won't be aware of it to prevent it. So Florian has already gone through the interventions for cachexia, and I'd just like to say that most of the interventions are multimodal because nutrition on its own doesn't help. You may have to add steroids or non-steroidal anti-inflammatory agents. Patients may need exercise. Cannabinoids were thought to be an appetite stimulant, but they're not really, there's no evidence to say that they actually work. EPA and fish oil has been shown to reverse some of the cachectic changes in patients with pancreatic cancer. And there are other drugs such as pentoxifil and thalidomide and a number of experimental agents for which we don't have much evidence at the moment. So we must approach these patients with a multidisciplinary approach. And you need to respect the other members in the team because each one is an important cog in the whole process. So you've got to have a good medical history and treatment history. A nutritional history should be taken. The patient's symptoms, they should not just be restricted to the physical symptoms, but we should also delve into the psychological symptoms that the patients may have, perform laboratory tests and nutritional assessment tests. And finally, we need to have a multidisciplinary approach to the decision making. We've got to have the patient at the center of the whole equation and have individualized goals for the patient, define realistic outcomes, determine prognosis and anti-neoplastic treatment. And the last thing we want to do is when the patient is on the end-of-life care pathway, we shouldn't burden them with unnecessary interventions that are just going to prolong misery. And finally, we need to come up with an individualized treatment plan. We've got to manage treatable causes of malnutrition, provide patients with nutritional counseling, give them artificial nutritional support if necessary, provide pharmacological support, and physical therapy and exercise. I'll briefly touch on immune-enhancing nutrition, and there's been a lot of interest in this in the past 20 years, where you give a cocktail of immune-enhancing nutrients like omega-3 fatty acids, arginine, glutamine, and sometimes even nucleotides. And a lot of studies have shown that this reduces both post-operative infectious complications and hospital stay. However, there are a few problems with these studies, and there's a lot of heterogeneity, and some studies have shown that patients who are malnourished may benefit more than those who are normally nourished. So although the meta-analyses do show benefits of immune-enhancing treatment, this hasn't become standard practice in hospitals. We also have to remember that some patients will have conditions which need palliative treatment. There are patients who will have gastric outlet obstruction, such as those with advanced pancreatic cancer, or those with, may have colonic obstruction with advanced colorectal cancer. And we may have to do surgical procedures to bypass these obstructions so that the patients may be able to eat. But again, if we're offering patients surgery, we need to make sure that they've got a reasonable time to survival left, because there's no point doing futile procedures in these patients. Again, nowadays we move towards stents, and these are self-expanding stents that can be put in the esophagus, the biliary tree, the duodenum, and the colon, and they help overcome these obstructions and help patients maintain their nutrient intake. So a suggested algorithm for treating the cancer patient would be to assess the nutritional risk or nutritional status at first, and if they're normally nourished or they have mild undernutrition, we may provide them with oral enteral nutrition for 5 to 7 days, but this is controversial at the moment. If they're severely malnourished, then we need to provide them with enteral or parenteral nutrition, depending on the state of the GI tract, for between 7 and 14 days. We've got to avoid prolonged starvation before an operative procedure and give them an oral carbohydrate drink up to 2 hours before an operation, as this has been shown to reduce post-operative insulin resistance. And finally, we need to have a multimodal package, such as the Enhanced Recovery After Surgery package, to help these patients recover from their operation as soon as possible. Now, you may say this chap has spoken for about 15 or 20 minutes, and he's given us very little evidence. And that's the reason. There is very little good quality evidence. And one would assume that a patient with pancreatic cancer would benefit the most, but this recent systematic review of 15 studies with over 3,000 patients has shown there is no evidence to support post-operative nutritional support in patients with pancreatic cancer. And you may think, this doesn't make sense. Yes, it doesn't make sense, because the problem with these studies is that every study has used different endpoints. Some have used physiological endpoints, some have used nutritional endpoints, and very few have used endpoints related to clinical outcome. There's a lot of heterogeneity in these studies. The nutritional status of patients at the start are completely different, and so we can't make firm conclusions. So finally, if you want a take-home message, we must remember that nutritional status is a prognostic factor in the recovery of patients having surgery for cancer. Nutritional screening is essential in order to identify patients at risk, and if we identify patients at risk, they should have a full nutritional assessment and perhaps even nutritional support in the form of either enteral or parenteral nutrition, remembering that these two routes are not competitive, but they are complementary. Nutritional support, if required for a longer period of time, should be given for a longer period of time if inadequate oral intake is anticipated, such as the patient who has delayed gastric emptying after pancreatic surgery. And finally, multimodal therapy is necessary to treat patients with cancer-related cachexia. Thank you.